course, if it's around this time, casualty 911. No, not around this time. Let me correct myself because most times we have casualty 911 at 10 in the morning. Okay, but for some reason we have to facilitate. We have to. All right. Anyway, folks, let me welcome each and every one of you to another edition of Casualty 911. With me here this morning, your host, Fawn. Good morning, Fawn. Welcome.
Good morning, Ilan. It's always a pleasure to be here.
And Happy New Year. It's the first time.
It's the first time we're
Yes,
seeing
yes,
for the
yes.
new year.
Yes.
Happy, thank you very much, and I hope both of us will have a wonderful year, 2024,
Indeed. God
as
bless.
well as
Definitely.
our listening public.
Right.
It's going to be a good year for all of
Of
us.
course. Of course.
Good morning to our listeners, our regular listeners, and our new listeners. Those of you joining us for the first time, those of you who are always here supporting, we appreciate it. As Ilan said, I am Fawn Minviel. I work with the Bureau of Health Education and I am your host today. Unfortunately, Louisa is not here. She had another engagement. And from last year, we have been doing a bit of alternating so that each of us can get some time in our specific regions, health regions, to get some work done, other work done. This morning, we have a very special guest with us, Dr. Ketura Edwin. We are going to be talking about leprosy or Hansen disease. It's always observed in January. Try to raise a little bit of awareness about the condition, but I don't think it's a condition we have spoken of at all on our program since we started, Louisa and I. Prior to that, I'm not too sure about that. But since we started, I don't think we've really dealt with the topic of leprosy or Hansen disease. This year's theme is Beat Leprosy and it's aimed towards, usually when there are certain conditions, people become very stigmatized because they have a condition, and those who are living with the condition may feel a little bit self-conscious and so on. So, in order for all of us to understand what the condition is and why, how we should treat those who are living with that condition, we have with us Dr. Edwin. Dr. Edwin is a dermatologist, but I will allow her to introduce herself because I think Dr. Edwin will do a much better job of talking about herself than I ever could. Welcome, Dr. Edwin. We really
Hi,
appreciate
good.
you
Hi,
joining.
good morning, everyone. St. Lucia, the listeners of Casualty 911. My name is Ketura Edwin Sobias, and I am the community dermatologist. Um, so I studied medicine in Cuba, completed my degree in about 2004, came back, did 1 year's internship at VH, worked afterwards on internal medicine and oncology. I then went back to study in the UK and obtained a master's degree in clinical dermatology from the University of Cardiff. And I returned to St. Lucia in 2010, I believe. And from since then, I've been working with the Ministry of Health and also in private practice. When I returned, I headed the HIV unit for about 1 year. And subsequent to that, so from about 2011, 2012, I really started with the Department of Dermatology, but working in more so in the community and um, seeing the patients out there in the health clinics.
Dr. Ed.
Okay, you heard me?
Yes, we can hear you
Okay,
very clearly. Thank you for
okay,
that
great.
introduction. And as I said to our listeners, you will be delving into the topic of Hansen disease or leprosy. So you can go ahead and tell us a little bit about the condition.
Okay, so leprosy is a condition that, despite the fact that lots of people seem to think it's an ancient disease and it doesn't exist anymore, is actually alive and very well, sad to say. It's a condition that's caused by a germ, a bacteria called Mycobacterium leprae, or there's another form, Mycobacterium lepromatosis. And this bacteria tends to affect the skin, The nerves that are found in the face, hands, and feet. It can affect the respiratory tract, the areas that help us to breathe, the eyes as well. So these are the areas in which we usually tend to get acquired through. The most usual form that we can get it is from someone who has a lot of the germ when they breathe and they expel lots of droplets through the nose and the mouth. We can also get it if we have maybe an injured skin or cut on the skin, and in some places, like in the US, it can be spread through contact with an infected animal. The name of that animal is a nine-banded armadillo. We don't have that form of contact in St. Lucia. So, in a nutshell, that's basically what leprosy is. It's a condition that tends to affect the skin, and we tend to see lots of lesions that will pop up at first, maybe pale, maybe copper colored, depending on the color of your skin. Usually, it tends to have a decrease in sensation or feeling. So you may realize you have a spot here and you're rubbing it, you're not really feeling anything. You may also notice decrease in sweating in the area and also maybe loss of hair in that area on your skin. If you don't do anything about it, then maybe you can get more of those lesions popping up. You can get lumps and bumps appearing on your body, on your ears, on your face as well. And again, if it's left unattended to, then this thing can move from just being on the surface of your skin and it can invade as well and affect the nerves. So when the nerves of the hands and feet are then affected, we can get then a decrease in sensation or feeling, loss of feeling to those areas. And if you're not able to feel, whether it's heat, whether it's pain, then you're likely to injure yourself. So think of it this way: if you hold a cup and it's hot, right away you drop it because you realize it's hot. However, if you're unable to feel that this is hot, more than likely you're just holding on to it and it's actually damaging the tissue. And thereafter, you may notice, hey, I've got this terrible burn on my hand. I don't even know how that happened. So that can happen quite frequently in persons who have leprosy unattended to for quite a while, that we get these, um, how shall I say, more severe complications with it.
You mentioned that it's contagious. Is it a condition that is very contagious? How easy
Mm,
is it for
no.
one?
So it is not what we would consider to be a highly contagious illness. So, for example, we just went through this COVID maelstrom recently, and it as well is one of those that is transmitted via respiratory droplets. But you'd notice you come into contact with somebody who had or has flu like symptoms, and usually within about a week to 2 weeks, you tend to start to get symptoms. Leprosy is very different in that it has a long incubation period. And incubation period is the time in which you will actually get the germ. You will not see signs and symptoms on your body, although it's inside of you, until when you actually become someone who shows a spot, a bump, a lump, or however it's going to show on you. Leprosy, it can go anywhere from 6 months to 20 years. 20 years, right? The average incubation period is about 5 years. So it is a long incubation period. So it's not a case where, for example, you go out, I don't know, just for a little lime and you meet a lot of people in a place, that you're likely to acquire it with short contact. So, for example, for a lot of healthcare workers who work with persons with leprosy, I cannot think of any, at least locally, case where they've acquired it from the job. You understand? So it's not something that is highly transmissible. It is usually found more so in persons who live with persons who have leprosy. So they're spending a lot of time with that person in a closed environment, right? Or maybe people who just spend a lot of time with each other. So maybe every day they're knocking dominoes in the cabaret for I don't know, many hours at a time. We have had cases like that that we've been able to go back and trace. This person actually acquired it from his friend. You know, they were always playing dominoes, I don't know, maybe 6 days a week and for long periods of time. So that's how we can get leprosy.
Okay, so Dr. Edwin, if a person is infected, the incubation period you said is quite long. So if a person becomes infected during that time until they develop any symptoms, would that person be able to transmit to another person?
So it is thought that yes, it is possible to transmit, but it's hard to determine if that's really the case. But the science thinks that yes, it is possible during that time to transmit. Let me make a note that most people, though they're exposed, let's say we're all exposed to it, the majority of persons have their own immunity, meaning their body will be able to fight off that germ. We have two main types of leprosy, and we have the milder form and the more severe form. The milder form, we will find about 1 to 5 lesions on the body, and that one is called paucibacillary type leprosy. And the more severe form, we have 6 or more lesions, right? It's usually found that persons with 6 or more lesions, they have a lower form of immunity against the germ that causes leprosy. And therefore, their body is not able to fight it off well enough, so they get a lot of it multiplying quicker and in a worse form in them.
Mhm. Are there any other ways of transmitting, for example, from mother to child, or is there any other form of transmission?
So we, according to the science states is via one, the respiratory route droplet, two, maybe injured skin, and like I said, through animals. No, there's nothing thus far that has come back saying, let's say, in utero or via the birth canal, any young baby will acquire it that way. So no.
So, Doc, in your experience, I suppose you have had a few patients with Hansen disease. Do they usually come in very early, at the early signs, at the early onset of the symptoms, or is it a case where you find that people usually come in much later?
Well, sad to say that due to the fact that leprosy is not very well known, we are finding that the majority of the cases we're finding are those that one are of the MB type, meaning the more severe type, and two, a lot of them do have complications, right? So that means we're not getting them early enough. We generally tend to see something on our body, and this is not related just to leprosy. We have a habit that we need to be sick to go to see the doctor, and we wait until, I don't know, it's not getting better in, I don't know, not 3 months or 3 weeks. We wait for 3 years, 4 years, 5 years. Some people will tell me, oh yes, I've had this for, I realize I've had this and it's not getting better. So I'm like, why didn't you come in before? They're like, I don't know. But a word out to persons out there: don't leave things unattended to for prolonged periods, health wise, whether it's on your skin or elsewhere. Anything that wasn't there before and has come up suddenly and is not going away, please get it checked out.
Yes, we do have a culture of wait and see in St. Lucia, I must say.
Yes, for all things, for all things. Very sad to see.
And usually if we don't think that we are being affected too much by whatever it is, then we don't head out to see a doctor
Well,
early.
like I said, if we leave it unattended to, then we start to see complications of leprosy, and complications can be, for example, permanent nerve damage. And again, I don't know if maybe you've seen, it's more common for us to see these in like diabetics, because diabetics as well tend to get lots of nerve damage, and you will see them talking about they get the burns on their hands, on their feet, they get ulcers. You can get very similar lesions and issues with persons with leprosy as well. And talking about diabetes and leprosy, due to the fact that we have a high incidence of diabetes as well, we sometimes have the comorbidity of somebody with leprosy also having diabetes, which makes treatment sometimes a little bit tricky and also difficult. Some of the treatments used for leprosy and its complications can sometimes cause spikes in blood sugar. And if you already have an issue with your blood sugar, then that makes it virtually impossible or very difficult, or have to use it in very small quantities. Whereas otherwise, we would be able to say, okay, let's just go ahead and use this if that was not an issue.
Okay, so you've spoken a little bit about treatment. Can we just go back a little bit and speak about how leprosy is diagnosed? So if somebody comes
Okay.
in with those lesions, how does diagnosis take place?
Okay. So generally, what we're hoping that over the next few weeks and months, we'll have a massive educational campaign so that persons on their own, of their own free will, can do self-examination. So it's very simple. Look at yourself without clothes on, naked, yes, in front of a mirror, and see if you happen to have any pale or lighter spots on your body, any lumps and bumps that weren't there from before. Areas where we frequently get lumps and bumps will be areas like your earlobes on your face. Um, and if you have been noticing that, one, you're not diabetic and you're frequently getting burns that will not heal on your hands and on your feet, you go ahead and get checked. You would see either the nurse or the doctor, and they refer onward to myself in the dermatology clinic. Um, Once I see you, then we would do a few bits of clinical testing. So, clinical testing, we would see if those lesions are indeed what we'd call anesthetic or they have decreased sensation. So, we will do a little bit of testing there. If I find, hey, right away, this looks like it's leprosy, the next step would be for us to draw some bloods, and we do bloods. In the event that we definitely are going to start you off on medication, we want a baseline to ensure that you are able to take the medication. And the next thing we would do is either take what's called a slit skin smear. And a slit skin smear is one in which we use a small blade. Please note the word small. And we put a little slit to the earlobes, elbows, knees, and if there's a lesion as well. And we scrape a little bit of what's called plasma, a little bit of clear fluid from there. So we're not going deep enough to draw any blood, just a little slit, and that is sent off to the lab, and they will be looking for the presence of the germs that cause the leprosy. They call AFBs. So they're looking for that under the microscope. The other thing that can be done is by myself, and that one is called a biopsy. A biopsy, we use something like a little cookie cutter, and we actually bore under the skin and take a small sample. And that as well is sent off to the lab, and they will look at it under the microscope. And they usually come back saying what type of leprosy it actually is, or if it's not leprosy, then whatever else it may be. So these are the things that are done to determine what exactly we're dealing with. So slit skin smear, we can do a biopsy, and we do bloods. The bloods will not determine whether it's leprosy or not, but it helps us get ready to actually give the patients medication or treatment for the leprosy.
Okay. So you've mentioned treatment a couple of times. Does that mean that there's a cure for leprosy? So for those people who may be a bit concerned that it's
So most definitely leprosy can be cured if we get it one early enough. So, like I said, if we have complications and we have issues with the nerves, then it's not that the leprosy part of it, the germ, can be eliminated and killed off. But if we have nerve damage, then nerves are one thing. Thus far, we have not been able to regenerate them or effectively repair all damage caused by the nerves. So it's very important, if and when you get a diagnosis of leprosy, that you start treatment early so that we can lessen the chances of complications ensuing thereafter. Treatment generally is what we'd call a multi drug therapy. So that means it's more than one drug at one time. If you have the milder form or the paucibacillary form, treatment will be over 6 months. And if you have the more severe form, then treatment generally is for 1 full year. So what we normally do, patients will get what's called dot therapy, and dot therapy is directly observed therapy. Once a month, they actually need to be seen at a healthcare facility, and in the presence of either the nurse or myself, we physically give them a part of the medication. Then, once they take it there in our presence, they go home with the rest of the packet. And for the next 27 days, because the packet has 28 slots, for the next 27 days, they take 2 pills until they come back and they bring us the empty pack and we do the whole process again. So that's how treatment is done. Apart from that, if we have again any complications with leprosy, if there's nerve damage, then there are other things that we do. So sometimes we give medication like multivitamin, some vitamin B. Sometimes we have to give oral steroids, but that is very case dependent on what is found.
Okay. So that being said, Doc, in your practice, what sort of age range or male versus female do you see in terms of
Uh,
leprosy?
so age ranges. So leprosy before, I'm just watching the figures. Before 2018, I had not seen. So again, I joined the team in about 2010. Before that, we did not have leprosy. We didn't see or find any cases in children. In 2018, I diagnosed my first child. I think the child was about 7. Then 2021, we had another child. That one was about 11. And then the year later, the person's relative actually developed leprosy as well. So in the past 5 years or so, we've had 3 children diagnosed with leprosy. And this is important because, like I said, leprosy is something that has a pretty long incubation period. So it can go anywhere from, let's say, 6 months to about 20 years. But
Mm-hmm.
when we can find children with leprosy, that is an indicator that we have active transmission in the community. So if a child is 7, they could have only acquired it in the past 7 years.
Yes.
You understand? Unlike somebody who maybe if they come in their 50s, then you're not too sure where and when they might have acquired it because they've been alive for a longer period of time. So it's important that we note that we still have active cases of leprosy out there in the communities. Probably they've not been seen and they're not treated. The other thing as well is that some persons they will get seen, they'll get diagnosed, they come to clinic, and then somewhere along the way, something I guess more important pops up. They get lost to follow up. We try and try and try to reach them, and some people they just kind of like drop off the face of the earth. But it's again important for us to remind persons that to safeguard yourself from getting worse, from getting complications, from spreading it to your family members and to other persons in the community. If you have the diagnosis of leprosy, you should come in and get your treatment done. And we need to do the treatment consistently. So once you start the treatment, we need to finish it. If there's a break for any period of more than 2 months, 3 months, then we actually have to start the process all over again. So it's really important, folks, that if you have the diagnosis of leprosy, remember it's curable. And a lot of people do really, really, really well on treatment. And they always, they're very pleased that by at least the second month into treatment, they can see a vast improvement before versus after. So that's my plug for the treatment.
Okay. So in terms of the treatment, does the patient remain contagious until they have completed the
So
entire course of treatment?
So absolutely not. Data or science shows as well that the likelihood of them passing, and in medicine we never say never, please note that lawyers are kind of like doctors, like, doctors are kind of like lawyers, sorry, we never say never, and because everybody's different, but
Exactly.
the likelihood of you passing on leprosy to anyone is significantly decreased by about 90% after your very first dose, just the first dose with the MDT, you are less likely to pass it on. But it's still important for you to complete the entire thing. Huh? You either your 6 months or your full year of treatment.
Okay. So for those people who have been diagnosed and you lose them to follow up, what how would you explain that transmission you spoke about within community?
Sorry, do you mind repeating that? I didn't hear you clearly.
Okay. You mentioned that some people are lost to follow up after initially starting the treatment.
Mm-hmm.
But you also mentioned a possibility of transmission within the community. So how would you link that loss to follow up with the transmission? Do you
Oh,
think it might
so
be
so so
to
the,
those patients or patients who have not been exposed to treatment?
So, what we try to do when we realize, or if we realize, now let me make it clear, that's not a usual phenomenon. I have to, according to the people, big up my patients. For the most part, they are very, very, very good at coming to clinic, taking their meds, and I have a great team. I work with two nurses. One is located in the northern region, that's Nurse Bonnet, and then I have another nurse that works with me down south, and that's Nurse Duncan. And if we notice maybe a patient hasn't come in for a week, 2 weeks, we call them. When we register the patients, we do an intake. So we'd find out, okay, what's your phone number? What's your daughter's phone number, your son's phone number, somebody, so that if we cannot find them or they're not coming, we're calling somebody else. Okay, where is this person? What has happened? I recently had a case where, yes, I asked. We hadn't seen this gentleman for a little while, so asked about him and asked about him, tried to get the contact. We couldn't find him. So, yes, we sent people out to try to find him. So, after a long time, it must be about 2 months of searching, we finally found him. So, sometimes it takes a little bit more effort than other patients, but we do our very best that if we notice there's someone who has not come to clinic, that we try our best to encourage them to come back in so that we can complete, or whether we have to start over again, start the process, because they will reap the benefits in the end.
And do you find that those patients that you lose to follow up are usually receptive to coming back into to continue
Well,
their
we try
treatment?
to encourage them. We cannot force persons to necessarily come back in, but we try and make it very easy for them to do it. If anything, and they're not able to come, so some people find it's very, very difficult for them to leave where they are and maybe come to a specified clinic, then we send it to the nearest health center. Or if that's a lot of trouble as well, then we try to maybe get the persons at the health centers to actually go visit them at their homes to encourage them to take the medication. We usually do what we can and what's necessary to ensure compliance with those patients.
Do you ever find that cost is an issue as it relates to um, continuing treatment?
So I should have said this before. It's a very important thing as well. All medicines for leprosy, especially what we call the MDT, all of those meds are totally free of charge to the patients.
Oh,
The clinic visit is free of charge. The labs are free of charge. Once in a while, there may be a stock out. I will not deny that. But for the most part, the meds to help control leprosy are free of charge. The one thing they probably have to foot the bill for is to find their way to clinic. The clinics as well, we've tried to distribute them. It's not just in Castries. There are clinics in Castries, Villefort, Dennery, Ancillary, Soufre. Where else do I do clinic? The Polyclinic. All of these places, we have derm clinics available. And again, depending on the patients and their circumstances, if they cannot come to clinic, then we try to get the meds to the nearest healthcare facility so that they can either go there for the dots, and if they cannot go, then maybe we make a special arrangements with them and their relatives to try to get the medication to them.
So, Doc, would you say that it's very easy to get an appointment into the clinic, or is it a walk-in clinic? How does it work so that our listeners out there have an idea of how they could access services to the derm clinic, the dermatology clinic?
So most of the clinics are by appointments. Um, so yeah, generally what I'd suggest, if you notice something on your body that wasn't there before, you can see your physician, your DMO, whoever's closest to you. I'll let them review, and if there's anything, they can transmit onward. They'd write a referral to the clinic. If you're in a place where it's accessible enough that you can come to the clinic, you can come in and book an appointment for the dermatology clinic as well. Either of these methods work, but I usually suggest get an appointment.
Okay, wonderful. So, Doc, is there anything else you'd like to share about the condition, or something that you'd like to share from your practice, from having
Uh,
worked with patients?
with regards to leprosy, I just would like to make a comment. The CMO recently, in her end of year address, made a statement that we had had 120% increase in leprosy figures between 2020 to now. And when I heard that, I was like, what? Really? And then I went back and I looked and I was like, 120%. But yeah, when we did the math, it really was about that. The reason why is that in 2020, we registered only 5 cases, and the year before that, 7. 2020, if you note, was the height of COVID. And during that year, we found that clinics in general, including the skin clinic, saw less patients. We had less people moving around. It's not that necessarily we had less leprosy, but we had less people leaving their homes for whatever reason. They were not coming out, they were scared. I don't know if everybody remembers that time, but sometimes you'd hardly find a soul out there on the streets. So it was persons generally with more emergencies in their mind that would come out. So we noticed in 2020, we only had 5 cases. In 2021, we had 7 cases. In 2022, we had 10. Last year, according to the CMO, we had 11, but there was another case that came in later. So we had about 12 cases to close the year last year, 2023. And this year, we've already had the confirmation of about 2 new cases already. Those samples were taken late last year, but then the results only came in this year. I would attribute the increase to, one, we've been doing a lot of training amongst healthcare workers to look out for it as well, so that they were able to pick up a lot. Because, like I said, a lot of the times patients will be seen by their DMO or the general doctor first, and and then they refer the patients onward to me for review, and we would take it from there. That's the usual thing. So this year, we hope to do a lot more education with the public. We will do continued training with healthcare workers so that we expect to maybe get a few more cases as well. And it's not necessarily a bad thing to have a spike in cases, in that means we're picking them up more
Yes.
effectively, and we would treat them hopefully earlier rather than later. And hopefully after that spike of numbers, then we should tend to get a decrease. Another thing we hope to start or implement this year, because we already got a supply of the medication, is something called post-exposure prophylaxis. And post-exposure prophylaxis is one dose of a drug called rifampicin that we will give to contacts or close contacts of persons with leprosy. So let's say I get it and I'm living in a home with 5 other persons. With the person's permission, then we go ahead, we screen the other persons who live there, and we'll be able to offer them this medication which would decrease the chances of them getting it. Please note the word decrease. Usually, again, in medicine, we never say this is going to prevent you from ever getting it, but it will most definitely reduce it, reduce the likeliness of you ever getting it from this person you live with. And afterwards, again, you can do it in the neighborhood. You can go out there, do screenings as well, and offer this drug to persons who live in close contact with the person with the leprosy. So that's a new and exciting project that we
Very
hope to launch later on this year. But as in everything, we first have to sensitize the public. We have to make sure we train the persons who will be going out there and doing the screening and actually giving the medication. So we're doing it right and we're making sure everybody's well trained in it. And then we shall launch it a little bit later on in the year.
wonderful. And Doc, a final little question from me. As it relates to leprosy and stigma, do you find that your patients have any sort of negative emotions or feelings or feel self-conscious about having the condition or about letting people know that they have the condition?
So again, it depends on how advanced or what stage they come in with leprosy. So there are some people who come in with what looks like a ringworm, and for the most part, they will not have any major issue with it. But persons who have more advanced leprosy, some of them do tell me that yes, they have an issue with it. I've had cases where one gentleman told me, oh, yes, he was put out of his house. His wife didn't want him to sleep next to her, even though he was taking the medication. Yeah, he had to sleep outside for the period of time. I've had other persons tell me, depending on what community they're in, people want to call him a gage, all kind of stories like that. Certain people tell me, yes, this person, they wouldn't want to sit next to them on a bus. So some persons have been, sad to say, at the receiving end of discrimination due to their outward appearance. So yeah, so it would be a good thing. It's not to stigmatize persons. When we're doing the sensitization, the focus will not be hey, I think you have it, so I need to stay away from it. If it is that you check that you have it, you go ahead, you get seen, you get placed on treatment for it. Yeah.
And also for the public, I think the public education that you plan to do will be very important in terms of helping people to understand how the transmission occurs, like sitting on the bus and that sort of thing.
Yes, it's highly unlikely, almost impossible that you sitting down next to somebody, whether it is for a ride from Castries to Grosile, which is 1 hour, or from Castries to Vieux, let's say at maximum 2 hours, 2.5 hours. It's very unlikely, virtually impossible that you're gonna get it in that short period of time. Okay.
Okay.
So again, the person's most at risk for leprosy. I don't think we've mentioned that, but risk factors for leprosy, one will be the close contacts of persons of leprosy, those specifically who live with them, very, very close neighbors, depending on the housing situation, persons of the male sex. And again, men are at risk for everything because usually they don't get checked out. So they will have something and they will not bother to come in and see what's going on. So again, they'll end up with the more severe forms, the more advanced forms and complications, and absence of BCG vaccine. And the last thing, would be persons from, of a worse economic background. Those from the worst economic backgrounds, the main reasons would be, again, usually poor living conditions, crowded living conditions, maybe poor nutrition, and lack of education in that they would not realize, hey, I have an issue and I should go get it checked out. So the emphasis is, if you notice something on your skin, on your body, that's not healing. Even if you've gone to see the doctor and they've given you this treatment once, twice, and you realize it's not healing, it's not working, you go back to see the doctor. Hey, doc, I realize this is not working. What else do you think we should do? In a respectful manner.
Yes. Okay. So Thank you so much, Dr. Edwin. I think you did a very good job of explaining so much in such a short period of time. And I'm sure the public is looking forward to that public education that you spoke about. I learned quite a few things myself. I did not know, for example, that the treatment is free. So I join you in encouraging the public to go and get those changes to their skin checked out, because as Doc said, it's free. The visit is free, the treatment is free. What more could you ask for? Let us
Indeed.
not allow ourselves to become to get those complications where you lose feeling. I mean, that's something that the diabetic patients go through sometimes, and nobody wants to have severe nerve damage from something that they, in a manner that they could have avoided. You could have avoided it
Oh,
and you
yes.
end up with nerve damage. Nobody wants to get to that point. So, Doc, I know you took some time out from your clinic this morning. Is it at Grosley Polyclinic?
Well, I have to get up there now.
Okay. So, thank you so much for joining us. We really appreciate it. And we
All
look
right.
forward to everything that is going to come on stream in terms of leprosy as the year proceeds.
Okay. So I'd like to thank you for inviting me. It was a pleasure being on board with you. And hopefully, I was able to give a little bit of knowledge to whoever's listening
A
today.
lot, Doc, a lot.
Yeah. I know it sometimes it sounds like a lot, but hopefully, the main thing is, let me leave this with you. Leprosy is here, it's in St. Lucia. We do not have huge figures of leprosy. Do not be alarmed when you hear it. Um, it is curable. We have the treatment for it. Look at your body, look at your skin, review. If you see something that wasn't there, and there are certain parts on you maybe you cannot see, so maybe use a mirror, or if you live with someone, ask them to check your back, the back part of your body out. And if there is, it usually again starts off as a pale area on the body, a pale patch,
So
which
on
is,
dark skin, it would look like a pillar.
yeah, uh, yeah, it's still lighter in color. Even if you're a light skinned person, it will be lighter than your usual color or coppery in color. On those who are very fair, a light patch on your body with decreased sensation. That's the usual thing. However, some persons may get, apart from just having the patches, lumps, bumps, tends to affect ears, your testes, hands, feet. If you're getting recurrent burns on your hands and feet, especially if you're not a diabetic and you're still getting all these burns, there's usually a reason why. So get checked out and get placed on treatments as soon as possible.
And,
Okay.
and Doc, somebody was asking about a patch. He says that usually occurs on children. Does it look similar to that?
Sorry.
Ringworm you referring to?
So yes, ringworm, the very early stages. I am not able to share my screen with you, but the very early stages of leprosy can look exactly like ringworm. Exactly. Um, that which is why I said if you notice that you have something, you've gone to the doctor, and maybe you've received treatment once, twice, they've given you oral meds, and it's not getting better, then it could be something else, right? If you see a lesion that looks like ringworm, the first thing
Oh,
would not necessarily
eczema.
be treat for leprosy.
Eczema.
First thing, treat for a fungal condition. So treatments for it would probably be an antifungal cream, a ketoconazole, miconazole, plus, if anything, maybe something oral, terbinafine, griseofulvin. All of these two are oral antifungals. But if you have treatment failure with those, and it's important to determine treatment failure is that one, you bought the meds, two, you apply the meds to the affected area for the specified amount of time, and you took the orals. If you're not responding to that, then it's something else. And the possibility of what something else is usually Maybe leprosy. It could be something other than leprosy. There are other conditions that can look like ringworm. Granuloma annularia as well is one of them. But leprosy, usually with the lesion, you will get other signs and symptoms. And again, the signs and symptoms would be maybe a decrease in sensation to the lesion, loss of sweating, loss of hair in the lesion, which we would not find in conditions, for example, like granuloma annularia. Some persons as well, they can tell you maybe at some point in time they lived with somebody who had leprosy, or I don't know, maybe they have some relative that had it at some point in time as well. So
Okay. Thank you so much, Doc.
okay, so no questions on the platform. That was it.
I think one other thing that you mentioned, and I think I would like you to repeat, because we have a tendency to try to diagnose ourselves. So we
I
see
like that.
stuff, and based on the signs and symptoms that we read about or we've heard somebody mention, we stay at home, and sometimes we treat ourselves without
Mhm.
ever going to a doctor. So I just would like you to speak a bit on that, and to reiterate what you said earlier, to say it again, to encourage, because I know people respect doctors very much. To
Okay,
say
so
it again, that they go
so
to
in
get.
summary, leprosy is a disease. It's caused by a bacteria. Usually tends to affect skin and the nerves. May affect the eyes as well if left untreated. If you notice you have a pale spots or lumps and bumps on your face, on your ears, recurrent burns on your hands and feet, then get checked out. If you get checked out and the doctor thinks it may be leprosy straight off, they will refer you onward to the dermatology clinic. Leprosy is only treated by, well, for the time being, myself, because I'm the only community dermatologist. But it is not a case in which that's okay, I don't want to go to that clinic or I don't want to see the doctor there. I will go, I don't know, by MNC and pick up some drugs. The medicine is only available from the government because government gets the donation from the World Health Organization, and those meds are stored in the government pharmacy and they then do the distribution. So that's why it's one is free of charge, and two, we only find it in within the public system. So all cases of leprosy, whether maybe you were seen by a private physician, a private dermatologist, and they think it's leprosy, they will still have to eventually send you to the clinic, the skin clinic, so that you can get your treatments and the required care within the public system. But remember, it's free of charge. So don't try to diagnose yourself. I don't know of any bush medicine that can work thus far to eradicate leprosy for the most part. I'm not knocking the bush medicine. I'm just letting you know that thus far, I do not know of any verifiable bush medicine that we have in St. Lucia that will cure leprosy. What we know that works is the MDT, and you can get that free of charge once you are enrolled into our clinic. So please come on in and let us see if you have it. If you have it, then we will be able to treat you. Yeah,
Nice.
Thank you, Doc. And
you're very welcome.
we really appreciate you joining us today. As I said, it's a novel topic for us. We have never had anyone come on to speak about leprosy, and you did a wonderful job. We really appreciate it. Have a good day
All right.
and continue the good work.
Okay. Thank you very much. Everybody have a great day. And remember, check your skin out. If you notice there's anything wrong, please come in. Thank you very much.
All right.
Bye.
Okay,
Thank
Doc.
you.
Bye
Bye
bye.
bye. Casualty 911.